Thank you for the opportunity to connect. A lot has been already said. I think we're all speaking the same language, same problems. And as summarized by the current president, who said that we all need to work hard, work smart, and most important, work together, because we have all these differences, very similar and very, very complex. And we have our own challenges. So I'm not going to get into any of these. I'll straight away come to one important thing, which was laid down by Dr. Yavagal. We released the white paper of Mission Thrombectomy, um, which was with the chair of healthcare systems from the government of India, Professor Paul, and that was the start of what I would say the vision of what can be done further. And most of the statistics have actually been taken by case study, and he actually couldn't present because of lack of time, and I guess it'll be published soon. It is the same thing that we are, there's a lot of regional disparity. It's not just that globally the numbers are dismal. And I see this trailblazing presentation by Dr. Martins and the China group. I mean, you're really way ahead. And I think when we were just commenting that we also have a national health mission, we said that we have to change to National Health Commission to make it probably better work. So there are problems, but within India itself, there are regional variations. There's a large difference between north, south, and west and east. And this is brought out very nicely in case study in his geomapping. The study, which is probably going to be published soon, case, but since still I had an access to the paper, so I read all that and I put this up. I know that you will not like it, so I'm not going to present this. So there are a lot of factors out here. So let me just first come down to what can be done, because all this has been spoken in today's thing, and there's a limitation of time, so it's really will be a repetition. So the key recommendations for policymakers when this paper was released was create a task force that includes this big bunch of specialists, and essentially the community physicians, which is probably the key word, because we never are going to have enough neurologists to treat stroke. That's a no-brainer, seriously. So it's in your face. We need to definitely to have the first responders, whoever they are. So we had the first thrombolysis in one state in India was performed by an orthopedician because he was the emergency guy. So why not? So he's performing pregnancy deliveries and the golden hour in MI and trauma. So why not stroke? And the second is the assess the stroke disease economic burden. I think it's been done. It's again carrying coal to Newcastle out here, and assess the efficacy of existing systems. And I think that's where there are huge issues. We have a lot of potential, and transforming this potential to possibilities and have that energy and drive to make an ecosystem which is sustainable first and then scalable. The kind of populations we keep adding on, and that is true for all across LMICs. So we keep adding on the developed countries' population every decade. So we are good at that. And then we assess the cost and therapeutic effectiveness of existing public and private health systems. Well, this is an issue because there are a hierarchical system of problems in countries. And in India, we have the three-tier system, which exists in public, and in a private, which exists on its own. 70% is private and 30% is public. And that's why probably we've been unable to drive this kind of energy as it could be done, say, in Brazil. Because we sometimes at our, these are like real, they're stonewalled into, because the public just cannot get into a dialogue with the private, and unless you have the public private partnerships and develop these stroke wheels, it's not sustainable for a huge country. And I think this is what is important. And establishing local and regional certification programs already been done. Arvind has spoken about ISA certification at the MBA certification that Dr. Martins has done with Jairaj. And unique set of policies are examples of effective policies, well, whatever. And then we have this funding mechanisms, and I'll come to this strokeonomics at the end of my presentation, which will be just a couple of minutes more. And stroke education program, well, it's all, again, it's the elephant in the room, which we keep talking about. And set up specialized regional thrombectomy systems, et cetera, da. Okay. So we have enhanced stroke center infrastructure. So currently we have 23% of Indian population reach an IVT capable. So what has been done? The strategic planning and resource allocation and establishment of new stroke centers has happened. So in the undeserved regions, at least the IVT is going on. The perfect examples are the Himachal Pradesh state out there. With help of Jairaj and with the Indian Council of Medical Research, Assam has come on board. And then with this, these are the outreach areas where there was nothing happening. And with public funding, now there are probably now 7 states in the country where IVT is public in the sense that it is free of cost. It's on the shelf, which I think is a huge development and a huge step forward. And it is free for those who come in time to the district level hospitals. But then have they graduated to EVT? No. And then the public-private partnerships are existing in the southern part of the country, where Vikram would actually, if he was here, he would have elaborated on that. That you have these wheels which are developed, so you can have in a big private center, EVT is possible. So in a public center, it's not. You have an IVT, you can get into dialogue and transport them there. It's possible now. It's happening. It's happening in the south. It's happening in the western part of the country, not happening in the north, including the capital, which is Delhi. I come from there. Then we have the regional disparities. The how do you assess that? Then this targeted development of stroke centers has happened, as I said before. Regional health policies focusing stroke brought in the Assam health minister, and after that, there's been a huge thrust. I mean, the health minister actually sat through, and then he started eating out of Jairaj's hand. So he's listening to him. So then development of telestroke networks. This has been possible. April 2014, we launched it in Himachal Pradesh. And I know what had happened in 2013. And I went to the health minister and the health ministry and said, look, you have something like a clot busting agent for MI. I don't have it for stroke. Then they sat up and said, you have something like that? I said, we do. And in 1995, it was launched in the world, and why not in India? And it was happening in the public sectors. So we just wanted the guidelines to be changed, or the guidelines have changed. And the last one was updated and released in November 22. We are all part of the orders and that includes both the lytic drugs, and then it have even the telestroke guidelines are out there. So it is up and running, and I'm happy to do that. Then we have mobile stroke units, which are now, I think the only mobile stroke units which are running are public and are there in Assam. There was a private public stroke unit which was in Coimbatore, which has now become defunct. They're using it for something else, scrap metal. And then training and development programs to increase number of specialists. Now that's where I do come in. The critical corpus of neurointerventionalists has gone up. Don't look at the watch, because this is my baby. I've done this because, you see, I was a member secretary for the DM curriculum to train neurologists, and we brought in that these guys have to perform CAT and actually observe an some interventional procedure before they're awarded the DM degree. That's in paper, December 31st, 2022. It's up there, and it's now up to the implementers to implement. Now I'm a grandmother, I'm out of this, but I still believe that something can be done about it. It's there. So the change has been brought about nationally. I hope it does. So we have this corpus coming up. We have the NEET program, we have the fellowships, we have the stroke fellowship of ISA. There's so much more happening. So I think we will have enough people. Then we have the infrastructure supply chain for EVT equipment, much desired to be done there. And then medical services for protocols for stroke patients, that's there. And then public awareness, we're all doing it. Focus on setting up rehab centers, yes. It's life after stroke and community-based programs. There are a lot of other trials. Now, I didn't actually, I wanted to put a big elephant out there, but then I couldn't. Didn't want to, because that's a hard part, the strokeonomics. And I'll end by this example. I moved to a private sector, and this is a big chain of corporate hospitals. And there are good interventionalists and there is a mandate to reach out into the periphery and reach out to your spokes. Talk to them and say that, do the IVT, transport us, and then, within 1 hour at least, they are in this hub. So people do bring in. So they do bring in. And then the ER, then you have this 39-year-old young woman, and there is an M1 occlusion, It is now within the window period of EBT, not obviously IVT, but or she's received IVT, what have you. So we say that, okay, we will do this. The family says, okay, what is the cost? And you need to tell the cost. And then you tell the cause and they debate. While debating, another couple of hours relapses. And then you say, oh, forget it. Let's use a used EVT. You know, that's also, we do all this, what we call as jugaad. We do it in India. And so we said, okay, let's perform that. Performed. And obviously she has a huge MC infarction. Now she has to go for hemicraniectomy. We know she can survive. The guy says, ICU cost is so high, we are going to take the lady away. And they took the lady away. It's heartbreaking. And this is everyday news, ladies and gentlemen. That's the reality. And this, I'm sure, is what example I've given you would be happening in all MIC. So it's not all, honky-dory and it's all not roses out there. We have to look at economics, and this strokenomics plays, I think, beyond social and cultural barriers, beyond everything. We also have the resources, the right allotment of resources, the right attitude and aptitude. You have to have the policymakers, implementers in your basket and talking the same language. It's probably happened in Brazil, and a big task for Jairaj. Now, you need to bring this change now that you're the president. And I think as a group, we need to address, including the pharma, the industry altogether. Thank you.